right, I guess first I just want to say good afternoon to everyone and thank the Society for Biomaterials for allowing me to speak today. A lot of this work was conducted, I guess, under the guidance of Dr. Sean Pinnison and Dr. Joel Corbett. So first I'm going to go through the background and significance, some of the things that a few of my colleagues have already hit on. You know, what is a hernia, types of surgical procedures, and some of the clinical complications that we currently see with these procedures, as well as try to hit on some of the mesh biomechanics and maybe the importance that this might play in the ultimate outcome of your ultimate clinical outcome. Then hit a little bit about my methods and results, mesh construction that we're using, the components that we're constructing these meshes with, the animal model that we chose to go with, and then conclusions and next steps for future research. So what is a hernia? A hernia is essentially a defect in the abdominal wall which allows viscera, such as adipose tissue and intestinal loops, normally confined in the abdomen, to actually push out and form what's known as a hernia sac. This can become quite a risky situation if your intestinal loops become strangulated with bowels, which requires surgical intervention quite rapidly. This is most commonly confined to the inguinal region in men. We see a 27% lifetime risk in men versus 3% in women, and this is due to anatomical reasons. You know, the presence of a spermatic cord, which actually travels in the abdominal wall through the inguinal canal. We see approximately 800,000 hernia repair procedures performed annually in the United States. So any type of improvements that we can, make in this field has the potential to affect a large number of people. So there's two types of ways that hernias are repaired. There's a suture repair, which has been around for about 50 or 60 years now. So essentially, the herniated region is approximated and closed with a suture. And then we have what's most commonly used today, which is a tension-free repair or mesh hernioplasty. So essentially, the surgical mesh is used to reinforce the abdominal wall defect and prevent herniation at that site. And there's three main procedures that are currently used. We have a transabdominal preperitoneal procedure where the mesh is placed laparoscopically and actually is in contact with the viscera. It's coming in from the bottom side. Because it's in contact with the viscera, you have a higher risk of adhesion formation. So typically, we like to see a TEP-type procedure, totally extraperitoneal if it's going to be a laparoscopic procedure, and then you have an onlay-type mesh placement procedure, which comes in over top. So there are several long-term complications that have been introduced with the use of these, mesh biomaterials. Some of these have already been pointed out, which is chronic pain, which is fairly common. We usually see reports anywhere from 10 to 30% in the literature. It's so common it has a term, and it's known as mesh inguinodenia. We also see fibrosis and abdominal wall restrictions, possibly due to the biomechanical profile of these mesh constructions, as well as mesh contraction due to fibrosis and chronic inflammatory response. In addition, the recurrence rates for hernias still remain high, even with the introduction of these materials. For inguinal hernia repair, we see recurrence rates long-term anywhere from 2 to 10%, and for incisional or ventral hernia repairs, we see anywhere from 7 to 24%. So mesh biomechanics. We know that soft tissues of the human body perceive and respond to mechanical stimuli. So this is especially true for fibrotic tissue, where it requires mechanical stimulation to get proper form and function to that tissue and get proper remodeling. The current situation that we have today, these surgical meshes are very mechanically stiff when you compare them to the actual native abdominal wall. So we're using a surgical mesh to physically reinforce the abdominal wall, and it's taking on all of that stress. This is similar to, when you're repairing a fracture and you look at Wolff's Law, where form follows function. If you try to repair that fracture with a very stiff, biomaterial, you're going to get ultimate failure and bad clinical outcomes because your tissue is not going to be able to properly remodel. So we're thinking we're seeing the same situation when we apply this very stiff mesh construction to actually repair a soft tissue. So the ideal mesh will ultimately share the load with the native tissue and not try to take on that load and create a perceived robust repair of the hernia site. So what we've created is a unique bi-component warp knit mesh. We make this mesh using a 4-bar warp knit pattern. The first 2 bars, we use a long-lasting high lactide material. So this is going to have an absorption profile that goes anywhere from 6 to 8 months. And then we use a fast degrading material for the last 2 bars, which actually, so the first 2 bars are knitting a sandfly pattern, where the back 2 bars are actually knitting a marquisette pattern. And what that does for us is it creates a low transition point. So when that fast degrading material actually starts to lose strength, it releases this high porosity, much more extensible type situation. So here's the initial mesh construction, and then when that first fast degrading material goes away, the actual area weight of that mesh drops quite significantly, and the extensional properties actually now move and shift and actually match what we see in the abdominal wall. So this results in short-term stability of the mesh construction as well as long-term extensibility for the patient. In addition, in this study, we attempted to apply a high caprolactone-based absorbable coating to attempt to add a triclosan-loaded antibacterial to this mesh construction. Because this is a multi-filament type situation, we're dealing with high lactides, which are fairly stiff materials, so we had to extrude them with a fairly high filament count. And because we do see a higher infection rate with multi-filaments versus, a monofilament polypropylene, we thought it would be good to have some kind of antimicrobial added to this mesh construction. So for this animal design, we did the surgery on a total of 14 Sprague-Dawley male rats, 3 animals per test group for the 6-week time point, and 4 animals per test group at the 9-week time point. And again, we looked at coated meshes versus uncoated meshes. And it involved the repair of a 2 by 3 centimeter full thickness abdominal wall defect. So essentially, a 2 by 3 centimeter piece of the abdominal wall was actually removed from that animal and replaced with a 3 by 4 centimeter mesh construction. And our tissue samples were stained with Masson trichrome to examine granuloma thickness and general tissue response. And what we saw when we actually measured the thickness of these granulomas is that the coated meshes actually had a higher or more intense foreign body reaction compared to the uncoated meshes, most likely due to the presence of, more material, and also, the degradation products of that E-caprolactone coating that's, reducing the pH in the area, causing a more intense tissue response. And this is possibly what, I guess the first presenter was maybe seeing with the Ultra Pro, is that Ultra Pro actually contains an absorbable component with it. So possibly degradation of that component could lead to more intense tissue response and more collagen being deposited. So here I have a few pictures of the Masson trichrome slides that we stained. One of the things to take note of is this fairly highly oriented collagen that was seen over each mesh construction. This could possibly be due to the biomechanical profile that this mesh imparts, again, having that early stability to kind of stress shield the wound and protect it, and then slowly over time you start to increase load and start to share that load with a collagen, maybe leading to higher, type 1, type 3 collagen ratios. And this is something that we want to look at with future work, possibly coating or staining with a, Picroceros red type dye, where we can actually distinguish between type 1 mature collagen versus type 3, which is your immature collagen. So the next steps that we want to look at is to actually create an animal model which effectively replicates the wound pathology that we see in mature hernias. Oftentimes you see in the literature this in-block type replacement technique, and that does not compare well to what we actually see in humans, where it's actually a chronic situation that could have been there for months or maybe years. So when we go in and we actually remove a section of the abdominal wall, how are we adequately replicating the situation that we see in humans, and can we actually draw any conclusions from these studies? So our first step is to, one, use a larger animal model, possibly mini pigs, and create or attempt to create a chronic mature hernia site prior to repair. In addition, we want to include some controls such as a heavyweight or lightweight polypropylene type material to look at the difference between our load transition versus having a static, very stiff mesh construction. In addition, we want to create and evaluate various load transition points. So as I spoke to before, that fast degrading component is going to dictate when you start to introduce load back onto the tissue. So we can use a high glycolide type material, for example, and do a 2 to 3 week transition point, or we can use something like PDO, and now we have a 5 to 7 week type transition period. So figuring out when is the most appropriate time to start introducing load to that tissue to get some of that remodeling to occur. In addition, we want to use a wound infection model to assess the antimicrobial performance of the drug-loaded coating that we were using in this study. So overall, the addition of a high caprolactone-based coating showed increased far-embodying reaction. In addition, we saw a high degree of collagen orientation at the wound site, possibly due to this unique knit construction where we do see short-term stability followed by long-term extensibility. Further testing is required using more appropriate animal model to truly assess the effect of a multiphasic type hernia mesh that we're trying to create here. So I want to say thank you, and I'll take any questions that anyone might have.
Can I ask you a question about your Mason trichome staining? You didn't indicate which side is close to the skin and which side is the peritoneal side. Yeah, that's this one.
Yes, so the side, I guess this side would be the skin, and this side would be the...
Is that the adhesion, caused the bowel adhesion or anything?
No, we didn't see any adhesion with this mesh. You can see adipose tissue on the other side of this mesh, and we didn't see any kind of visceral adhesions to the material itself.
Okay, thank you.
One more question. Now, actually, you mentioned in your introduction you are going to run some biomechanical evaluation. Biomechanical evaluation, are you planning to do this, or you have data?
Yes, we have data on, I guess, the mechanical properties that were reported in a previous SFB submission.
Oh, okay, thank you.
But yeah, we were able to see an actual 2 to 3 week type load transition point where the mesh construction now shifts to, instead of stress shielding the tissue, you start to actually introduce load back onto that soft tissue.
Could I ask a question about the contraction? I know this is an ongoing complication with a lot of meshes. With your particular design, with the different sizes of pores, did you see a difference, or was there a normal contraction as one would expect?
Contraction wasn't one of the endpoints, I guess, we used in this study, but one of the theories that we're looking at to a possible cause of mesh construction is possibly the stress shielding, because we know that tissues of the human body, they live in a certain mechanical environment. So when all of a sudden you remove all the mechanical tissue, the body's going to say, hey, something's going on here. There's an opening that I have to close. And what we want to try to do in future studies is actually look at myofibroblast activation and see if, trying to match the extensibility of the actual abdominal wall, do we actually reduce myofibroblast activation, because now that tissue that's encompassed by the mesh is actually able to see some of those forces.
Thank you.
All right.